Hi, and welcome to AAHPO's American Armenian Health Professional Organization's TV Health Program. I'd like to thank Holy Name Medical Center sponsoring today's program. And we have an interesting and common topic today to discuss. The topic is hernias, and I have with me Dr. Mark Egazarian, which is a surgeon, board certified in surgery, and we'll be discussing the hernias with him. Welcome, Dr. Egazarian. Hernias are very common, and there are so many different types of hernias, and patients come to the office and we are trying to guide them before we send to the surgeons to see they get proper information and probably surgery afterwards. What is the hernia anyway? How would you define hernia?
Well, a hernia is an abnormal defect in the abdominal wall. The human body is comprised of muscles. The abdominal cavity, any cavity, is walled off by muscles, and sometimes we get a defect. Either it can be born with one, or one can develop as we age. For example, is walled off all around by muscles, and sometimes we can develop a weak spot or a hole. We can either be born with one, or one can develop as we get older, and what allows whatever's on the inside of that hole to bulge out.
Bulge out, and then there are different parts of the body in the abdomen. Let's say in the groin area, we have and belly section,
Yep.
right?
Yep. What perhaps people are most familiar with are in the groin. We see these hernias very commonly. Once again, to be born with them or develop it.
But in the groin, there could be two different ones too, right?
Yes.
How we differentiate with those two?
Okay. The person who has the hernia is not too much difference. It's basically a bulge where there's not supposed to be a bulge there. A lot of times, most prominent can be seen when somebody's straining or when they're standing up. They may have a hernia bulging out in the groin crease, basically where the leg meets the hip. And when they lie down, it may go away. Yes.
Sometimes they have no pain at all. There's a bulge there, but there's no pain. But sometimes there's significant pain
sometimes,
with the hernia.
Yeah, some people will get a dull, achy pain sometimes. Sometimes there may be no pain at all.
So what is the danger of the hernia if they have hernia, there's a bulging there, and they have, let's say, minimal pain? And they come to you and they say, well, I have this bulging and I want to do something about it before something happens. What is that something can happen?
Well, this is why we generally try to repair these hernias when we find them. As I said, the symptoms can sometimes be minimal, a dull ache, just discomfort, have something bulge out where it doesn't belong.
What actually is bulging out is actually intestine. Yeah? It's small intestine.
It can be basically anything on the inside that belongs on the inside that's bulging out through the hernia. Can potentially be a problem.
Right. We don't want really that hernia to go into that strangulation event, which is an emergency, and they might have an cut of the intestine, versus if they catch beforehand, before the strangulation, you can have a simple surgery.
Absolutely. This is why, as I said, whenever medically feasible, it's a good idea to have a hernia fixed once it's first encountered, because there's a big difference in doing an elective operation when it's not an emergency, and we use better techniques, and there's less injuries, less potential injury to the patient.
Let's talk about the surgery types then. Certain times they say, okay, I'm going to have a laparoscopic surgery. Certain times they say, my doctor said it's going to be a cut, but no laparoscopy. What is the difference between those two?
This hernia surgery has been going on for really the last 100 years, but if not, have been most of the developments, although somewhat longer. And it kind of boils down to a couple of basic principles. Anytime, as I said, the underlying problem is a hole within the muscle. The problem is there's two problems that the hole has. First off, there are things that are stuck in the hole that don't belong there, whether it's the intestine, whether it's fat. That needs to be replaced to back where it belongs to. And then you have to fix the hole one way or another. 100 years ago, when we didn't have the sophisticated materials, prosthetic materials that we have today, the only real option is to basically sew the hole closed.
So we push the content inside where they belong
and close everything up.
Put it together and close it. Suture.
How we do that varies a little bit depending on the position of the hernia, whether we're dealing with a groin hernia, an umbilical or belly button hernia, or an incisional hernia. That's the basic concept. The problem with that technique is, as I said, we're stretching the hole closed. One good cough, one good strain.
It can reopen again.
The chance of the hernia coming back and needing further surgery was unacceptably high. Several decades ago, as we've developed more sophisticated materials now, we usually do what's called a mesh repair. And we use that same concept regardless of whether we're dealing with a groin hernia or another kind of hernia.
So you put the mesh in.
And this has the advantage that we're not stretching the tissue. It's a tension-free repair. and the chance of the hernia recurring, coming back and needing further surgery is much lower. In the case of a groin hernia, hopefully 1-2% of the time will be further surgery. In the case of an incisional hernia, those can be far more challenging, more complicated. Without the mesh, they can recur as often as half of the time. With the mesh, those numbers are lower, although not as good as with the groin hernia.
When you get the mesh in, a mesh could be covering probably both sides of the groin area. If there are both hernias, it can be covered with one mesh.
I think, or at least it can be dealt with at the same time. We're going a little bit now. As I said, the idea, regardless of the approach, is trying to cover the hole with a piece of mesh. Once we know that that's our goal, the question is how are you do it? Whether we do a traditional open operation where we actually make the incision right where the hernia is, and we place the mesh there, or you mentioned the laparoscope, which is a video camera that we use for a lot of surgery within the abdominal cavity, such as gallbladder surgery.
Hernia surgery can be done with laparoscope.
And with most hernia surgery, it can be used with the laparoscope also. The laparoscope offers some different advantages. In the case of a groin hernia, since there's two sides to the groin, some people have a hernia on one side, some people have a hernia on both, two separate hernias, one on each side. If we're doing open surgery, you're kind of stuck. You only really can repair the hernia at a time, where you are.
In terms of recovery, in terms of one traditional way to cut and then repair, and the other one with the mesh. What is the recovery time for each of them?
Everybody is a little bit different. In general, most people with the laparoscopic repair have a little bit faster recovery. It's usually a same-day operation where you go home the same day as the procedure, not an overnight stay. And then say we're from a few days to a week or two before really you get back to a more normal level of activity.
Let's put all this thing together. So we have many different types of hernias, and then there are basically two different techniques, that laparoscopy and open surgery, and then any of them really can reoccur, but you said probably the mesh will be a little more safer possibly in certain situations.
Well, in general, when for most hernias, it's feasible to use a mesh, the outcome is better, the risk of it coming back is better. There are some separate concerns. The big one is infection. Both the mesh itself can develop an infection, and this is kind of why it's so important to repair a hernia electively when it's not an emergency, because that's a safer
less chance of infection,
less chance of infection. If we have a emergency hernia operation and there is compromised intestine, a lot of times because of the presence of infection, we cannot do a mesh repair. We have to rely on the other techniques. Which can have a higher chance of recurrence. So.
Dr. Agazarian, thank you for coming to this program and enlightening us about the inguinal hernias or other general hernias. Hopefully we'll see you in another program.
Well, thank you for having me.
Now it's time for this week's article. It is magnesium supplementation and physical performance. Magnesium has a fundamental role in muscle relaxation and contraction, and it is essential to energy metabolism. Magnesium deficiency is associated with increased inflammation, increased oxidative stress, and impaired calcium balance in cells. Therefore, magnesium deficiency can impair exercise capacity and reduce physical performance. Elderly people are particularly susceptible to magnesium deficiency because of inadequate dietary intake, less efficient magnesium absorption, and greater loss in urine and stool. Researchers from Department of Medicine, Padova, Italy, investigated the effect of magnesium supplementation on physical performance and muscle strength in a sample of healthy, still physically active 139 elderly women. They were given 300 milligram magnesium oxide for 12 weeks. Their findings was that magnesium supplementation had significant positive effect on physical performance. It improved gait, walking speed, balance, and lower extremity strength. Conclusion of the study was that magnesium supplementation is important in preventing or delaying the age-related decline in physical performance. Besides magnesium supplements, you can get your magnesium from whole grains, avocados, beans, nuts, green leafy vegetables like spinach, and fish, especially halibut. Good health is precious and priceless. Stay informed. For up-to-date medical information, visit AAHPO's website, aahpo.org. I'm Dr. Orhan Karadoprak. See you at next program. So long.